Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Akram Ruslan. I will present to you my case report. Challenges in diagnosis of cerebellar abscess with atypical features. Differentiation of infection and tumor in brain is important because both have totally different management. Brain abscess and brain tumor have their own radiological features, but atypical imaging features can give confusion for the correct diagnosis. Therefore, it is very important to have thorough clinical pictures in addition with imaging. Many non-neoplastic diseases can present as space-occupying lesions, mimicking brain tumors. Some of these diseases have benign character and managed without histological confirmation. However, diagnosis is commonly missed in the pre-operative setting and many patients are unnecessarily exposed to the risk of surgical procedures. I present to you a case of a 16-year-old previously healthy female presented with on and off fever for 2 weeks associated with giddiness and unsteady gait. On examination, she had positive right cerebellar signs. ESR was raised. However, other laboratory tests were unremarkable. Initial CT brain was done and showed an ill-defined non-enhancing hypotension in the right cerebellum, causing local mass effect to the fourth ventricle. MRI on day 3 of admission showed a similar mass at the right cerebellum with a similar local mass effect. It showed a central heterogeneous T1 hypointensity with T2 hyperintense irregular wall and shows subtle ring enhancement in post-intravenous gadolinium sequence. Looming artifact within its wall, which you can see as a dark circle here, present in the GRE sequence, and presence of blooming artifact on DWI and ADC present. So this is the image of the 3 months after the treatment. We show almost no lesion in the right cerebellum. So initial impression of post-infarct hemorrhagic changes or low-grade astrocytoma, such as pilocytic astrocytoma, were given. However, in view of a young patient with fever and positive cerebellar sign, a revised diagnosis of right cerebellar abscess was made. After 2 courses of intravenous antibiotic ward, the repeat MRI, which I showed earlier, showed significantly smaller right cerebellar lesion with resolved cerebellar symptom. So, it is very important to review all MRI sequence in a standard examination, especially the pre-contrast T1, DWI, and NDC. The clue for brain abscess is the presence of a smooth hypointense capsule on T2 image with central pus that produce restricted diffusion due to its high viscosity, which is not typical for brain tumor. Looming artifact on the wall and the central lesion represent the hemosiderin deposition, which represent bleeding in the abscess wall, which is not typical. In fact, no calcification was noted and no microscopic hemorrhage could be identified on the CT brain prior to the MRI brain study. So, it is very important to have a correlation with conventional MRI sequences and the clinical pictures in determining the diagnosis of brain abscess. Thank you.